Welcome, everybody. Welcome to another episode of PEM Rules, the Pediatric Emergency Medicine podcast. I'm your host, Yaron Ivan, and today we're continuing to discuss some more rules in the assessment and plan category. Rule number 32. Any child with a seizure-like, syncope-like, or loss of consciousness-like presentation gets an EKG. I can't tell you how many times I sit in my emergency department and EMS comes in with a child that has a slam dunk story for first-time seizure. He dropped, he had tonic-clonic-like movements, he bit his tongue, became incontinent. Somebody called EMS. Sometime on the way here, he's back to normal. And just by the history, I'm certain the child had seizure. And as you know, in the emergency department, unfortunately for me, there's just no way I can prove this was a seizure. And if the child is back to normal, I honestly don't work them up. But I always get an EKG. The reason is, going back to rule number 1. Remember, it's not the patient's job to prove that they're sick. It's my job to prove that they're not. So if the patient had syncope or even seizure, I would argue he's probably going to be fine. Maybe he has epilepsy. Most of the time, those kids do very well. Most of the time, even during seizures, their oxygenation is fine. I rarely do anything for those patients, even in the emergency department, since the seizures stop on their own. Certainly something like syncope is a benign diagnosis, but I do not want to miss any child with arrhythmia, although those rare. Something like prolonged QT, Wolff-Parkinson-White, or Brugada syndrome come to mind. So any child that I see with loss of consciousness, seizure-like, who's back to normal, honestly, I send them home, but I always get an EKG. In my mind, kids who had seizures and are back to normal really need 3 things, none of which I can do in my emergency department. They need a neurologist, they need an EEG, and possibly an MRI. But an EKG is my responsibility to do in order to rule out arrhythmias that potentially can put the child at risk if he's discharged. So any child with a seizure-like, syncope-like, or loss of consciousness-like presentation gets an EKG. Rule number 33. If the patient can't walk home, he should not be going home. This, I think, is a rule that I heard from my colleagues in the adult or general emergency department. I think it's just a good rule to follow. Really, if a child can't walk, 2 things have to come to mind. Number 1 is the pain that prevents him from walking not in control, meaning I failed to treat his pain adequately. And even if the pain is from a benign diagnosis, I just think it's a bad idea to send someone home with suboptimal pain control. The second thing that comes to mind is, am I missing something? I think it's important to realize that neurological conditions that perhaps prevent the patient from walking are really hard to pinpoint in the ER. I really can't do a very comprehensive neurological exam. I certainly cannot do an MRI. So really I have to think, am I missing something that prevents the child from walking? I can do a CBC and a CMP, but those are not particularly helpful most of the time. So if the patient can't walk, I really have to entertain the possibility that I'm missing something, and he probably should stay for a more comprehensive workup. So remember, rule number 33, if the patient can't walk home, he should not be going home. And that can be even if the diagnosis is as simple as transient synovitis. Usually, from my experience with transient synovitis, after a good dose of Motrin, the kid does much better. May be able to walk better, the limp is gone, or something like that. And if I see none of that, I really entertain the possibility that I'm missing something, and if the child cannot walk home, he should not be going home. That's why we have the admission option, and that's why there are diagnosticians upstairs who can hopefully work this kid up and pinpoint the problem. So rule number 33, if the patient can't walk home, he should not be going home. Rule number 34, any patient that received CPR prior to his or her ED visit should be admitted. I think this rule stems from the fact that I recognize as a pediatric emergency physician that my interaction with the patient is simply a moment in time. If I see a child in the ER, no matter how well he looks, but somebody on the way to the hospital thought that child needed CPR, especially if it's a healthcare worker like a bystander nurse or a primary care office, no matter how well the child looks, I need to recognize that maybe something serious is going on and I just don't see it, with my 1 or 2 hour visit in the ER. I think it's a bad idea to send someone home after he or she really truly needed CPR, and whether they truly need CPR or not, I may never know. As a pediatric emergency department physician, I recognize that sometimes some things just have to declare themselves. Maybe the fever is secondary to meningitis and the kid just looks okay right now. But if a patient that came to my ER needed CPR just a few moments ago, it's probably a good idea to do a workup, but if you fail to find anything serious, keep the child for observation just to see that he continues to do well. So rule number 34. Any patient that received CPR prior to his or her ED visit should be admitted. Rule number 35. Positive popsicle sign means the patient is ready for discharge. That may sound funny to most people, but I truly believe in that rule. I don't even remember where I heard it. If I see a patient when I walk into a room, let's say a toddler, a 3-year-old, sitting up, having a popsicle, I don't know what the patient has, but he's probably good to go. I think it's important to recognize that a 3-year-old toddler who's sitting up, holding a popsicle, having the popsicle, enjoying the popsicle, probably does not have anything serious. If his temperature is 104 but he has a positive popsicle sign, most likely the temperature is not secondary to meningitis or pneumonia or bacteremia. If he presents with a closed head injury but he has a positive popsicle sign, most likely there's no serious injury like a subdural or something like that. If he presents with abdominal pain and he has a positive popsicle sign, my concern for a surgical abdomen is very, very low. By the way, it's a positive iPhone sign for a teenager who sits in bed texting his friends. So, positive popsicle sign or positive iPhone sign for a teenager means the patient is most likely ready for discharge. Rule number 36. Don't do something because you can. Do it because the child actually needs it. This rule goes back to our capabilities in the United States 2020 or 2021, I should say, to do things. I think we all know that when a patient comes to the ER, we can do a lot of things. Any patient with head injury can get a CT. It's literally a click away. Any patient who vomited once can get Zofran IV and a PO challenge. But I think it's really important to recognize that sometimes we just tend to overdo things. And it's really important not to do something because we can. We should really actually do it because the patient needs it. My favorite example is when I see a child with a musculoskeletal injury who has no swelling, minimal pain, great range of motion. I explain to the mom that an X-ray only enables me to see the bones. And if my concern for a fracture is so small, there's really no need to get an X-ray just because the child had a musculoskeletal injury. Another great example is when I have a resident present a patient who vomited once or twice, looks well, and he wants to give Zofran and a PO challenge. I think it's important to recognize that a child that vomited once, is not tachycardic, and looks well, probably has mild or moderate gastroenteritis or maybe some food poisoning for which Zofran is very effective. So in my mind, it's totally fine to give the mom some Zofran prescription, give good anticipatory guidance, and send the child home right away. I don't think that a child that vomited once truly needs a PO challenge, which is often an hour and a half in the emergency department. So don't do something because you can. Do it because the patient actually needs it. And that is it for today, guys. Thank you very much for listening. Let's review what we learned. Rule number 32. Any child with a seizure-like, syncope-like, or loss of consciousness-like presentation gets an EKG. Rule out those arrhythmias. Rule number 33. If the patient can't walk home, he should not be going home. Is there good pain control? Are we missing something? Rule number 34. Any patient that received CPR prior to his or her ED visit should be admitted. We need to recognize that sometimes things just have to declare themselves. Rule number 35. Positive popsicle sign for a toddler or positive iPhone sign for a teenager means the patient is probably ready to go home. Rule number 36. Don't do something because you can. Do it because the patient actually needs it. And that is it for today, guys. Thank you very much for listening to PEM Rules, the Pediatric Emergency Medicine podcast. I'm Yaron Ivan. I hope you enjoyed the episode, and I hope you tune in the future. Have a great day.